So there are indeed some things that make liver cancer a different cancer, and I will try to explain what are these nuances of liver cancer, and particularly of HCC, that involves not only why cancer is developing in a certain person, but how can it be diagnosed and how can it be managed? And I can advance that this is different, certainly different from other tumors. In general, I mean, cancer is the result of a series of insults that a normal cell receives over time. As we grow old, the cells become old as well. And a cell being old, that means that it has suffered from different exogenous factors over time. But probably the most important one is needing to replicate. Every time a cell replicates and gives birth to another cell, there is a possibility of the genome being damaged. So you just have to imagine that over time, the possibilities that just at random genomic alterations can occur are increasingly possible. Of course, there is some genetic predisposition. Some patients have inherited alterations in the genome that make them more prone to developing cancer in general. But age and the exogenous factors are the most important ones. Well, in liver cancer, what happens is that during our life, we can be exposed to certain factors that chronically damage the liver and produce chronic inflammation of the liver. And chronic inflammation means needs have to divide more often. And it also means that they have to divide under stress, under a stressful scenario. So in a scenario where genomic alterations, changes in the genome, are more likely. And the most common situations where this chronic inflammation of the liver occurs are when you consume alcohol in a chronic way, not necessarily in what the general population may believe is a harmful amount of alcohol. You don't need at all to be an alcoholic to have some sort of liver inflammation due to alcohol consumption, even within the range of what could be considered usual, common, even healthy. Of course, there are some chronic infections, what we call chronic hepatitis, that induce chronic inflammation. But very interestingly, there is also a very common situation nowadays in developed countries, which is the metabolic syndrome, which is a combination of obesity, diabetes, and arterial hypertension, or hypercholesterolemia, where not in all patients, but in a few, this metabolic syndrome leads to chronic liver inflammation. And when chronic liver inflammation persists over time, the liver can have an increasing amount of fibrosis. Fibrosis means scar. So you have inflammation. The liver is very, very efficient in curing the inflammation in the same way that when you get operated, the wound healing leaves a scar. Wound healing in chronic inflammation in the liver can lead to scar accumulation. And when scar accumulates in a significant way, we call that cirrhosis. And we will see why in a minute. On top of that, those are the three main external factors that cause liver cancer. Smoking is also deleterious, and there are some rare diseases that in some selected cases may also lead to the development of liver cancer. And there we have some protective external factors. One is female sex. For reasons that are not entirely known, by far, liver cancer is more, and HCC in particular, is more frequent in males than in females. And coffee consumption is also a protective factor by reasons that we don't know very much. So for any person that has chronic liver inflammation, drinking 2 to 3 cups of coffee is a good thing to do to prevent liver cancer. So this is what a healthy liver looks like. If you've ever gone to the butcher, you would see this is quite similar to any other animal's liver. And this is what a liver with cirrhosis looks like. Cirrhosis comes from a Greek word, and it does mean scar. So is the scars in the liver that produce this very easy to see change in the liver. What you see in the surface is also what is happening inside the liver. So you just have to imagine how different the tissue is from a healthy liver to a cirrhotic liver. The liver is like a sponge. It's very easy to go through for liquids. And in this slide, that might be look a bit busy, I would try to explain. Can you see the pointer? I hope so. So
we can see.
Okay, so you see here the healthy liver, and 80% of the blood that goes through the liver comes from a vein that we call the portal vein. Is this one? The portal vein takes all the blood from the intestines, the large and the small intestine, and the spleen. This is a huge amount of blood that goes through the liver. Why? Basically, because the liver is the great factory in the human body. So it uses all the things that we eat and are absorbed in the intestine. It has the first chance to get them and use them to transform them and make any particular thing that in the human body is needed, and in particular proteins, hormones, all kinds of things. So that's why the liver receives all this amount of blood flow. So when the liver becomes cirrhotic, it's not so easy for blood to go through the liver. There is a resistance to blood flow. And because of this resistance, there is some congestion in the portal vein. This is what we call portal hypertension. Like arterial hypertension is the elevated pressure in the arteries, portal hypertension is the increased pressure in the portal vein. And it's a consequence of cirrhosis. When cirrhosis is mild, portal hypertension is mild. As cirrhosis progresses, portal hypertension increases. And what are the consequences? One of the main consequences is that in the cirrhotic liver, the blood that cannot go through the liver finds its way bypassing the liver using neighboring organs like the stomach and the esophagus. And now the veins of the esophagus and the stomach the veins have to carry the blood from these two organs, but also this blood that is diverted from the circulation of the liver. This is an increased amount of blood, and these veins become dilated, and dilated veins are called varices. So portal hypertension leads to the formation of varices in the esophagus and the stomach. We will see why this can be dangerous. It also leads to congestion of the spleen. The spleen enlarges, and the spleen is a storage for blood cells. So when it is enlarged, it can sequester some of the blood components, like the platelets. And in cirrhosis, platelets go down. Also, leukocytes or white blood cells can go down, but basically, and more importantly, platelets go down. And finally, when there is increased resistance in the liver, the blood cannot go through, and then this congestion of the liver may make liquid pour out of the liver. The old doctors 500 years ago said the first time they operated on patients with cirrhosis, they say the liver cries, because it's the liver that is pouring liquid into the abdominal cavity. So these are the main consequences of cirrhosis: portal hypertension leading to varices in the gastrointestinal organs, to increased formation of liquid in the abdomen, and to enlarged spleen. What is, if the portal hypertension is very, very high, what happens is that cirrhosis becomes what we call decompensated. Cirrhosis can be totally asymptomatic for many, many years, and it may not pose any grim prognosis in a patient. But when portal hypertension is very high, then the amount of liquid can be also quite high. This is what we call ascites, or the varices in the esophagus can rupture. You see, this is a jet of blood from a variceal bleeding. Or the liver can shrunk, and so there is no sufficient liver tissue. And then the function of the liver is not good. When the function of the liver is not good, usually bilirubin elevates in the blood, and this makes the skin and the mucosa, like in the eye, yellow or yellowish. We call this jaundice. So jaundice means insufficient liver function, and we have important complications from rupture of varices in the GI tract, and from the formation of ascites and swelling of the abdomen. So this is cirrhosis. This means that if liver cancer occurs in a patient, in a person that has cirrhosis, in very advanced cirrhosis, then this person has two diseases that are one as important as the other. And sometimes cirrhosis is more important than cancer. And cancer is just a bystander phenomenon. It's something that is there, but does not impact on the prognosis and patient's symptoms and life. Okay, let's go. This is cirrhosis. Let's go back to liver cancer. Because there are different cells in the liver, we have different types of liver cancer. Most of the cells, more than 90% of the cells in the liver, are hepatocytes. When cancer occurs, or the malignant transformation occurs in hepatocytes, we have hepatocellular carcinoma. Some other cells form the bile ducts. The liver produces biles and is collected in ducts that take the bile to the intestine. Well, these cells, when they have a malignant transformation, what happens is that a cholangiocellular carcinoma or cholangiocarcinoma appears. So we have two different types of tumors. The most common one by far, 90% versus 10%, is hepatocellular carcinoma, and I will focus the rest of my a presentation today on this. What is important is, and this is quite different from any other tumor, because the causes of chronic liver inflammation are at large preventable, liver cancer is at large preventable. We can vaccinate or treat hepatitis B. We can treat and eradicate hepatitis C. We can try, this is a more difficult thing to do, to avoid the metabolic syndrome. And if this happens, we are truly preventing patients from developing cirrhosis and eventually from developing liver cancer. But even if we don't prevent it, even if the healthy lifestyle is not followed, or in countries where hepatitis B or hepatitis C treatment are not available, we still can do an effort to detect early liver cancer. The most effective ways is detecting early cirrhosis, but if not, we can still detect early liver cancer. Because it takes a long way from the time one single malignant cell is transformed in the liver until the time a tumor is visible, more than 100,000, more than 100 million cells, and even more to the time when this tumor is large enough to produce symptoms. So in between the time when the tumor is detectable and the time when a patient would eventually develop symptoms, we have a screening window. If we detect tumors at this stage, the likelihood that the tumors can be cured are much higher. And this is the rationale for conducting screening in every single patient with cirrhosis or intense chronic liver inflammation. And why? Because it saves lives. What you see here are survival curves. Survival over time due to liver cancer. You see 5 years after diagnosis, and this is an old slide. Today, the numbers would be higher. When we compare at that time, that was more than 10 years ago, China versus Europe versus Japan, there was an increasing rate of patients surviving 5 years after diagnosis, with Japan being the best performing country. And what is the difference in Japan? They have a national screening program. This is what lies behind this increased number of patients cured from liver cancer. So this is one of the things that makes liver cancer unique. We know the roles that causes, we know the causes of the cancer. We can prevent them. And because we know the population at risk, we can do effective surveillance on them. There is another thing that is unique to liver cancer. Usually, I would say not usually, for any other liver cancer, the diagnosis is based on a biopsy. In HCC, this is sometimes not needed. If a patient has cirrhosis and a CT scan, an ultrasound, or a magnetic resonance imaging has certain features, then the diagnosis of HCC is established without the need of a biopsy, a very unique situation. And there are other differences that have to do with treatment. But before we talk about treatment, we have to talk about stages. Tumor stages, mean that we classify the spread, the amount of tumor burden in any given tumor, in any given type of tumor, in order to establish a prognosis and provide some guidance to select the best possible treatment. And in HCC, we have 5 different stages. This was a classification that was developed in Barcelona, in Hospital Clinic, and this is why it is called Barcelona Clinic Liver Cancer Staging System. BCLC is how we call it. And we also use numbers and letters for this. Very early is 0, early is A, intermediate is B, advanced stage is C. And I have told you there are 5. There is an additional 5th one, which is BCLC D, or terminal. And this is a situation where tumor burden does not matter. What matters is cirrhosis. And any tumor burden in the presence of an advanced decompensation of cirrhosis is called the last stage, D stage. Very early means we have a single tumor less than 2 centimeters in size. Very early cancer. Early means any tumor that is single, no matter how large the tumor is. Intermediate stage means there are multiple tumors, usually with some measurable size, but there is no disease outside the liver, not even invasion of the veins. When there is invasion of the portal vein that I have mentioned before, and this is something that some liver cancers like to do to get into the vessels, or there is spread with metastasis in distant organs, lymph nodes, lung, or other organs, we call this advanced stage. In general, in cancer, you have a tumor. Please think about colon cancer or breast cancer. What you do is you resect the tumor, you take the tumor out with surgery. And if the tumor is more advanced, there is no use in removing one single tumor location, so you treat with drugs. And there are many things in between, many combinations in between. In the liver, we have some unique tools that we call intra-arterial therapies. And I will explain later what these are. But this is also very unique to liver cancer. Besides surgery and systemic therapy using drugs, we have these intra-arterial therapies that I will try to explain in a minute. So if a tumor is detected early, how can we get rid of it? So basically, if the tumor arises in a healthy liver, something that rarely occurs, we can resect a part of the liver, a portion of the liver. There are 2 problems with this. One is you cannot take a very small piece of the liver. The liver can be cut in certain slices and not others. But most importantly, if the liver has cirrhosis or intense chronic inflammation, it will not work as well as a healthy liver. So removing a significant part would not be compatible with a normal life. In these cases, when a patient has cirrhosis and you need to resect, to take out a large portion of the liver, what you can do is take the whole liver out and put another liver in liver transplantation. So there are 2 forms of resection, and this is also absolutely unique. There is no other cancer in the body that is treated with transplantation in general. So 2 forms of surgery: resection, taking apart; transplantation, taking the entire liver out. But we have another technique that we call thermal ablation. A needle is inserted in the middle of a tumor. Heat is applied. The tumor is heated to an extent where it's no longer viable and is eliminated in situ, we call it. It's eliminated without the need to remove it. This only applies for very small tumors. Basically, tumors are not larger than 2 centimeters, sometimes 3 centimeters, but certainly not larger than 3 centimeters. So when we have small tumors with thermal ablation, with liver resection, in some cases with liver transplantation, we can procure a cure for these patients. And this is why early detection is so important. If we have not been lucky enough and there is a larger tumor burden, more tumors in the liver, you see this is an angiogram. I will explain what this is later. This is the liver, the shadow of the liver. What you see in darker colors are different tumors here. We treat these with intraarterial therapies. Intraarterial means that we need to go to the hepatic artery that takes only 10% of the blood to the liver, but more than 90% of the blood to the tumors. The tumors get connected to the hepatic artery to get blood from. We can get access to the hepatic artery by putting a needle in the groin, in the femoral artery, making a catheter go upstream, find the artery, and then here contrast is injected. We can see these are the branches of the hepatic artery. Now, if in one or more of these arteries, we inject some particles that occlude these arteries, the blood is not flowing anymore, and we produce an infarction of the tumor, just like a heart, a myocardial infarction, but selective of the tumor. Another way to treat is we take this catheter and we inject some particles that are radioactive. If these particles accumulate inside the tumor, and they do, then millions of particles of radioactive particles inside a tumor is like putting a radiation machine inside the livers, inside the tumors. You are able to deliver a very high amount of radiation very selectively to the tumors without harming the non-tumoral portions of the liver. Very selective tools to treat liver cancer when it has not spread outside the liver. When there are metastases in other organs, surgery is not possible, intraarterial therapies are not meaningful, we have to rely on drugs. One also unique thing about HCC is that it's very resistant to chemotherapy. And the usual chemotherapy that we use in other cancers does not work in liver cancer. Fortunately enough, in the last 2 decades, we have been able to discover good ways to treat liver cancer using drugs. In the beginning, we had what we call targeted agents. These are basically oral drugs that you take in pills, usually every day, and they provide an effective means of slowing the growth or even arresting the growth of the tumor. And this leads to a better quality of life prolonged significantly over time. So patients are able to survive longer with better quality of life. In the last 5 to 6 years, we have witnessed the success of immunotherapy. In immunotherapy, we use intravenous drugs that are provided in the day hospital. There are different drugs that we now use in combination. And there are two things that have changed the scenario for patients with liver cancer needing drug therapy. One is that despite being intravenous injections, they are tolerated very well. Of course, they are not free from the possibility of producing significant adverse events, but they do so in a true minority of patients. All in all, in general, they are very well tolerated. And it is more important in patients in whom the immune system can be potentiated in a meaningful way. The potency of the immune system is enough to produce very deep responses. And very deep sometimes means complete responses, and sometimes mean complete responses that last for, we now know, 5, 6, 7, 8, 10 years, as it happens in other tumor types. These are not the majority, unfortunately, yet, but this is a major shift in the use of drug therapy that is already providing higher expectations for patients that need drug therapy to treat liver cancer. And now we are starting to study, and now we have some evidence to see that they might even work better if we use these in combination with the other therapies in early stages. We hope that this will not only change the prognosis of patients with the advanced stage. We already know that. We hope that this can even more meaningfully change the prognosis of patients at early stages. And because of this complexity of liver cancer, the background of cirrhosis with its own complication, a situation where complications can occur and the prognosis may be impacted, the need to discuss different therapeutic options provided by different specialists makes it absolutely mandatory today that patients with liver cancer are taken care by a multidisciplinary team, a true one, where surgeons, interventional radiologists, these are the guys that do the intra-arterial therapies, but also medical oncologists, radiation oncologists, and hepatologists. And not only that, nurses, psycho-oncologists, physiotherapists, nutritionists take care in a holistic way of every single liver cancer patient to provide the highest chances of cure. And if this is not possible, the best possible care leading to the longest possible lifespan with the best quality of life. And with this, I will stop here and take any questions that you may like to.
Wow, Bruno, thank you. Absolutely brilliant. I have still tons of questions, although I think this was the most precise and easy to understand presentation I've ever seen. Andrea, your hands are up, and any comment from your side?
Yeah, I just thought it was very thoughtful, and thank you for not having size 8 font on your slides. And so it was very straightforward, and most of it I knew, but it was still great to see it, and it was very easy to understand. So thank you so much.
Thank you, Andrea. Good to see you.
So are there any questions from your sides? Friends, colleagues? I will start with one question. Bruno, I think you have explained the different stages. Early stage, so BCLCA, and then intermediate, ABC. But to be honest, what is the difference between the terminology staging and grading? Can you please re-explain?
There is no difference. In general, we doctors use grade when we talk about differentiation. So highly differentiated versus poorly differentiated tumors. But this is not very meaningful in liver cancer. Staging is what really matters because it defines not only prognosis, but most importantly, the treatment that you have to apply, or the tools that you have to consider, because it's not one single treatment. It's not one stage, one treatment. It's one stage, one set of tools that needs to be discussed. A different stage, a different set of tools.
Okay. Can I ask the next question? So you have very well explained, I guess, the situation that decompensated cirrhosis on the one hand and cancer are in the end two different diseases. We have two different strategies for. And what do you think patients with a decompensated cirrhosis, in which setting they should be? More in a hepato setting or more in oncology setting, or how does it interact? I know from your centers and many other centers that they have a very close cooperation, but unfortunately many patients does not have the situation to go in a center where these different teams work so closely together as in your town or in other towns we know. But what should you or should we recommend to those patients who write emails, text us? So I have discovered that I have decompensated cirrhosis and a tumor, but shall I go 400 kilometers this way or 800 kilometers that way?
Yeah, the short answer would be, in case you need to choose, in a situation of decompensated cirrhosis, it's best to be treated by a hepatologist than by a medical oncologist. Why? Because it's the decompensation of cirrhosis what makes a larger impact in prognosis. So trying to make, as a matter of fact, in decompensated cirrhosis, you cannot operate. Usually you cannot use intraarterial therapies. And many oncologists or hepatologists will be reluctant to treat with drug therapies. So first thing is to get compensated. And once you are compensated, you can the number of tools you can use is expanded and you have more options. So of course, what matters is if there is a possibility of having a team of hepatologists and oncologists, that's the best possible situation. But if not, taking care of the liver in a situation of decompensated cirrhosis is the most important thing.
Okay, thank you. Any other questions? Otherwise, I would like to know. So
I like your questions, Akim. They're really good.
Okay, great, thanks. Okay, so because this is also a little bit the question of setting. So we heard from many members from around the world that sometimes patients are treated by the radiologists, sometimes by the hepато-oncologists. And Bruno, can you please explain what is the difference? Why is this different setting there?
Yeah, this has to do with the structure of the health system. There are countries where patient is directed to one single specialist, and this is, for instance, quite common in the United States, less in Europe, although some countries in Europe have a similar situation, like in Italy, for instance. So if you have a tumor that, and you consider, you or the first doctors that sees you consider, okay, intraarterial therapy may be an option, then this patient will go to the radiologist and the radiologist will decide. As I mentioned, the best situation is having all people together to discuss what are the best options. But if not, and I think this is one of the concerns we at ILCA are trying to tackle this year, is try to make sure that your specialist has thought about the other possible options. So if, for instance, you're in the front of a radiologist saying, TACE, transarterial chemoembolization, is what I would recommend you. Okay, ask him, is this the only options, or what are the other possible options I may choose from?
Yeah, and I guess
that's
that's
an important thing to do.
Important point, patient empowerment. So the better patients are informed of the different options, the better it is to ask these questions. So I myself have seen this in the clinic when I was doing a training there. So on the first day, so it was dominated by radiologists, and the next day it was by others, and it was completely the same case but different results. But one other thing, I'm not a doctor, but
Andrea has a hand raised.
Yeah. Okay, Andrea first. Sorry.
It's just more of a comment of what we see. We have a private HCC community for patients and caregivers, not a Facebook group, but an actual private HIPAA compliant community. And I think it's important to understand that so many patients are also seen in a very rural setting. They're not going to an NCI center. They don't have a multidisciplinary team. And so I'm thinking of one family in particular. They lived in such a rural part of Texas that the community oncologist, general oncologist, not a specialist in HCC, came to that town 1 day a week. 1 day a week. And he was awful, absolutely awful. And even when the patient and the family came forward after joining our community, they learned about all these other treatment options that he never even mentioned, perhaps didn't even know existed. And even when they overcame insurance hurdles by getting approved for a patient assistance program, that general oncologist refused to do those therapies, refused to even try. Now, luckily, they had a great GI, but that was still, I think, an 1.5 to 2 hour drive away. And so he ended up sort of being their primary because the relationship was better and he seemed to have more knowledge about HCC. But it's a real struggle for patients who are not seen in a multidisciplinary setting. So just kind of laying that groundwork, with the US, that it's something we're seeing that's a pattern and it's challenging.
Certainly.
Yeah. And maybe one last question from my side, and then 2-3 recommendations. As I said, I'm not a doctor, and if I see these pictures of a decompensated cirrhotic liver, so I wonder, Bruno, is there sometimes this overlapping of having this HCC and CCA? Because if I would be, maybe I'm naive, but if everything is damaged, I can imagine that the bile tract inside the liver also damaged and has developed bile duct, CCA. Is there an overlapping possibility with cholangiocarcinoma?
There is what we call mixed tumors, but they are very rare. Rare means is in general is about 2% of all liver tumors, so they're really rare. And the thing is that they typically do not respond as well to therapies as either HCC or cholangiocarcinoma. So these mixed tumors are a real challenge to treat.
Yeah. Okay. And then I would like to make some recommendations to all of you who are here in the meeting. So Bruno has said very, very precise that early detection is key. And this is really, the way how we can help to make or to save lives. And so therefore, I would like really to mention two things. First is, so thank you, Bruno, again. It's on the ICM webpage. You see this resource here of the liver cancer training videos. And thank you, Bruno. It was great pleasure to have you here together with the cirrhotic patients and to explain all the things you have explained today in a very, very good way. The other thing, and this is something I like to promote a little bit, the self-assessment tool, because that is something, Bruno, you also has helped us with setting up the self-assessment tool. This self-assessment tool is a risk assessment tool for those who are at risk. Easy questions, half for hepatocellular carcinoma, the other for cholangiocarcinoma. It can be translated in all languages, can implement it in all social media or web pages. It can be tailored. So please contact us. There's a kind of more or less 24 hours, 7 days support to introduce this. The other thing is, and I think that is also absolutely great, is that Bruno himself is very, very active within ILCA, the International Liver Cancer Association. And I also like to show you here that there is a lot of educational part within the ILCA website. So there are webinar series, there are guidance, there are liver cancer podcasts. And it would be great if you use these tools that has been developed by ILCA's team. And of course, many, many things, especially the latest guidelines for intrahepatic cell carcinoma, etc., has been developed by Bruno. And we would really like you that you promote ILCA's resources to the medical colleagues, but also to the patients and more advanced colleagues, because it is also great to see that there are resources for the awareness, and we need to raise awareness for liver cancer holistically. And you see here the advocacy programs, awareness month, they're doing a lot of programs, and especially in Africa, you're very, very active. And of course, you have absolutely great information for patients provided that can be used internationally, because ILCA is an international liver cancer association. And I think so. Yeah, I just can pledge you and ask for your support using these existing resources, combine these resources with your own resources. And especially to those, for example, with you, Vitor, you're representing UPRA colon. And of course, there are overlapping risk factors sometimes to develop colon carcinoma, but also liver cancer. And because of lifestyle-induced and other genetic factors. And I think so. Yeah, we have to work together and we have to promote. And for me personally, Bruno, it's a pleasure to have you as a great doctor, as a friend, and not only as a coffee waiter. But the last words, of course, is up to you, Bruno. And from my side, I would just say thank you. Hopefully see you next week in Vienna. And Bruno, the last words up to you.
Yeah, I would just like to replicate. I would like to thank you all. Thank you for being here and listening to me. That's the most direct way of saying thanks. But also thank you for all the things you're doing. Nothing that we can do alone and individually, like as persons, but also as institutions like ILCA, could be useful. Really, if don't spread the words. Every one of us spreading the word to each other, and I think this is the only way to go. We can to do prevention. We can do general awareness, but for early detection, we need to focus on patients with risk factors, and early detection is by far the best way to go in trying to save lives. Thank you very much.
Thank you, and see you all soon again, and have a nice rest of the day. Thank you very much, and bye-bye. Take care.
Bye.
Thank you
Stay
so
healthy.
much.